Now next is a LGV, that is Lymphogranuloma Venereum. Okay, that is a 2013 UK national guideline. It is caused by the invasive serovars L1, L2, L3 of Chlamydia trachomatis. This we have already seen. Okay, so Chlamydia trachomatis, there are many serovars D to K are responsible for urogenital infection, and this LGV is caused by the L1, L2, L3 serovars, especially the L2. L2B serovar, that is dominant strain in UK and Europe, and that is responsible for outbreak. Organism is lymphotropic and infects lymphocytes and macrophages. Okay, so there are very specific things about the UK and this LGV. It is hyper endemic among MSM population. More than 99% cases in MSM they are seen. Strong HIV association. 78 to 83% LGV cases are HIV positive. LGV patients are 8 times more likely to be HIV positive as compared to non-LGV chlamydia. Okay, co-infection rate, other STIs are common. HCV co-infection is around 14%. No significant heterosexual spread in UK. It is rare in female cases linked to bisexual partners or travels. Endemic regions. So here we should remember MSM population is more associated with the HIV and also associated with the proctitis. Okay, so this triad, if you get, you think about the LGV. MSM, HIV and proctitis, think LGV. So if you have got MSM, HIV patient and proctitis, think about LGV. Okay, so clinical features, it has got 3 stages: primary stage, secondary stage, tertiary stage. Primary stage, the incubation is very long, 3 to 30 days. It will be in form of papule, pustule or shallow ulcer. Often it is transient and unnoticed. Site will be mainly the coronal sulcus in male, and in women it may be posterior vaginal wall, foresheet or cervix. In extragenital it will be perianal, oral or tonsillar ulcer. Okay. Then secondary stage, that is LGV. In MSM population, you will get a LGV proctitis. Seen in 96% of MSM cases, there will be rectal pain, anorectal bleeding, mucoid hemopurulent discharge, tenesmus, constipation, fever, malaise. Okay, and it will mimic IBD. Okay, or Crohn's related presentation or rectal cancer. Okay, so hemorrhagic proctitis in HIV positive MSM. Think about this LGV. Okay, and second, there will be lymphadenitis or buboes. Okay, there will be tender lymphadenitis, so tender inguinal plus femoral lymphadenopathy. It is unilateral, buboes, and there will be suppuration and sinus formation, and this typical Groo's sign. Okay, so but this is seen in only 15 to 20% of patients. Okay, so if you get this Groo's sign, think of LGV. Okay, so Groo's sign, because of the involvement of the inguinal and femoral lymph nodes, you see separation of the inguinal and femoral lymph nodes by the inguinal ligament will give rise to this Groo's sign. This is seen in only 15 to 20% of cases. There can be systemic spread leading to fever, arthritis, pneumonitis, perihepatitis, and reactive arthritis is reported in MSM. Now, next stage is tertiary stage. It is rare. Okay, it will lead to the chronic inflammatory destruction leading to proctocolitis, fistulae, stricture, fibrosis, and scarring. Okay, it may lead to the vulval destruction also. It is more common in women, this vulval destruction, and rare in current MSM outbreaks. Okay, because this is mainly seen in MSM. If it is a female, there can be vulval destruction also. Then there can be genital lymphedema. There can be chronic suppuration association with rectal cancer. Okay, diagnosis: when to suspect LGV, proctitis plus MSM plus HIV, will think about LGV. There will be inguinal lymphadenopathy. Groo's sign will be there. You will get a genital ulcer. We will exclude the gonorrhea, HSV, and syphilis. Okay. Now the test of choice: NAT for Chlamydia trachomatis, and if positive, you have to test for LGV specific. That is L1, L2, and L3. Okay. You will test specific. So you will do the NAT testing for Chlamydia trachomatis, and if it is a positive, you will go for LGV specific DNA testing. Okay. So only detection of LGV DNA will confirm the diagnosis. Then specimen to be sent, you have to take the swab from ulcer base or the rectal mucosa, rectal and pharyngeal swab, urethral swab, first catch urine. If it is a bubo, then you will take the lymph node aspirate with a 21 gauge needle, okay, through the healthy skin. Saline inject and re-aspirate if non-fluctuant. Okay, if it is non-fluctuant, you will take the saline, you will inject and then re-aspirate. Other diagnostic clues in cases of rectal polymorphonuclear cells, you will get 10 to 20 polymorphonuclear cells per high power field. That is predictive in HIV positive MSM. Histology, you will get a cryptitis and crypt abscess. There is no crypt distortion as you see in the IBD. Okay, IBD will have the crypt distortion. Okay, so what is not reliable alone? Serology alone is not reliable. Okay. Now coming to the treatment. Now LGV, you have to treat for 3 weeks. Again, the doxycycline is the treatment. The organism is same, but like for chlamydia trachomatis, the duration there it was 1 week only. But here you have to treat for 21 days, 3 weeks of treatment. Okay, so 7 days of doxycycline is not sufficient for LGV. Alternative will be azithromycin, but multiple dose regimens preferred over erythromycin. Evidence is limited. Erythromycin is less favored. So this we have seen MSM plus HIV plus proctitis LGV, confirmed with LGV specific DNA, not just chlamydia and NAT. Treat for 3 weeks, not for 7 days. Growth sign is very specific but uncommon. Only 50 to 20% what we have seen. It mimics Crohn's disease and rectal cancer. High STI and HCV co-infection rates. Okay. Now coming to the LGV management. What will be the advice to the patient? Invasive but curable bacterial STI. If not treated, then it may lead to permanent sequelae such as stricture, fistulae, lymphedema. Then symptom improvement is expected within 1 to 2 weeks of the antibiotics. Avoid unprotected sexual intercourse until patient and partner will complete the treatment and follow up. Provide clear verbal explanation, written information. Then MSM specific counseling will be high risk for HIV and SCV acquisition, risk reduction for unprotected anal intercourse, traumatic anoprotective practices should be there. Recreational drug use and anal dousing and anal enema. These are the shared equipment will increase the LGV risk. Okay, so HIV LGV counseling goes beyond condoms. So it's not only the barrier contraceptive, but you have to talk about the behavioral risk also. Okay, so what are the EMQ related step in patients while screening of these patients for the STI? This we have already discussed. Genital ulcer disease. We'll think about the H. ducreyi, Trypanosoma pallidum, that is chancroid, syphilis, HCV, and Klebsiella granulomatis, that is donovaniasis. Okay, so proctitis screening will be required for Neisseria gonorrhoeae, syphilis, HCV, and other testing also you have to do HIV and SCV also. Okay, so lymph node aspiration and biopsy if malignancy or atypical infection is suspected. The most important part is the treatment. Treatment of LGV. It requires prolonged therapy more than 21 days due to systemic and lymphatic spread. LGV DNA persists up to 16 days after starting the treatment. So that is why 7 days treatment is not sufficient. Okay. So why 21 days? Because it is a lymphotropic organism plus delayed DNA clearance. Okay. So recommended regimen is a doxycycline 100 mg BD for 21 days. Second line will be erythromycin 500 QID for 21 days. And third will be the azithromycin 1 gram weekly for 3 weeks. Okay. Alternative will be minocycline or tetracycline. Then moxifloxacin 400 OD. Only after doxycycline. If the doxycycline fails, then go for moxifloxacin 400 OD. Okay. Then single dose azithromycin is not indicated. So these are the regimens what we have seen. It is a 21 days treatment, mainly with the doxycycline. Alternative will be erythromycin. Minocycline will be given 300 loading followed by 200 BD, but 21 days. Tetracycline 500 QID for 21 days. Azithromycin regimen is 1 gram per week for 3 weeks. Moxicillin 400 OD for 21 days. But what is recommended by CDC is the doxycycline. So we'll remember 3 weeks of doxycycline. Okay. Accompanying measures, fluctuant bubbers, we will aspirate through the healthy skin. Surgical incision you don't have to take. You will aspirate. Okay. If you take the incision, it will form the sinus. Okay. Provide adequate analgesia. If it is a tetracycline allergy, then the drug of choice will be erythromycin or extended azithromycin. Okay. Test of cure will be advised. Pregnancy and breastfeeding, erythromycin will be the drug of choice. Azithromycin may be considered, but go for erythromycin because azithro is a 1 gram per week for 3 weeks. Erythro is a continuous for 3 weeks. Okay. So test of cure is mandatory in pregnancy also. Okay. Then HIV positives treatment will be same as HIV negative. Now, what are the adverse effects of the doxycycline? It can lead to the GI upset, photosensitivity, esophageal ulceration. So the patient should take with the water and stay upright for at least 20 minutes. Erythromycin can cause GI intolerance, diarrhea, cramps, etc. Then contact tracing, trace contacts 4 weeks before symptom onset, or if the patient is asymptomatic, then you have to trace for 3 months if it is a asymptomatic LGV. If the patient is symptomatic, then last 4 weeks of contact have to be traced. If the index case is asymptomatic, then you have to trace it for last 3 months contact. Okay. And contact should be tested for rectal, urethral, pharyngeal, cervical as applicable, and you will give preventive treatment of doxycycline 100 milligram BD for 21 days. So partner should also be treated. And how many partners you have to treat? If the patient is symptomatic, you will trace the partners in the last 4 weeks. If the patient is asymptomatic or the index case is asymptomatic, then you will test for 3 months partner. Okay. So follow-up, clinical follow-up until the symptoms resolve. Early disease 1 to 2 weeks follow-up. Chronic disease 3 to 6 weeks follow-up. Routine test of cure is not required. If doxycycline is completed 21 days, then routine test of cure will not be required. Okay. If needed, perform after 2 weeks after the completion. Avoid false negative, false positive NAT. Okay. And you also have to test for syphilis, HIV, hepatitis B, hepatitis C. So just in nutshell, LGV 21 days of doxycycline, MSM plus proctitis plus HIV, LGV unless and until it is proven otherwise. Buboes you go for aspirate, don't incise. Test of cure is not routine, but pregnancy the drug of choice will be erythromycin.